Right, all right, all right. Good afternoon, everyone. And welcome to our February 2023 Health Equity Jam session. It's in honor of Black History Month, but the music is courtesy of our lovely invited speaker for today, Dr. Esa Davis. And I'm sure I saw a lot of appreciation for the beautiful voice of India Ari and just the uplifting and inspiring message, which I'm sure we can all use today: strength, courage, and wisdom.
Amen.
So thank you, thank you, thank you. So anyway, welcome everyone. It's so good to see all of you. And it's even more exciting for me to be able to introduce you to my longtime colleague and friend, Dr. Esa Davis. And so I'll give you a sort of a formal introduction to her, and then we'll move more into our fun facts, which we always enjoy doing because we don't stand on, ceremony and formality here. This is always a relaxing and an uplifting place to be together for us to share our experiences and, gain new insights always. And so everyone's welcome. So first of all, Dr. Esa Davis is an associate professor of medicine and clinical and translational science at the University of Pittsburgh School of Medicine. She wears many hats there. She is a family physician by training clinically, but she also directs a tobacco treatment service. She co-directs the Clinical and Translational Science Institute's KL2 Scholars Program, and leads a number of different career development training programs for biomedical researchers. And as you guessed, probably from the title of her talk, her research areas of interest are understanding perinatal determinants of adverse maternal cardiovascular health outcomes, as well as improving treatment strategies for tobacco use disorder. But I think she's going to be focusing on the former today. So anyway, so that's the formal part. Now we're going to move into the fun facts. So our first fun fact is related to one of Dr. Davis's multiple gifts and talents. So I'm going to have you all sort of guess what other talent does Dr. Davis have besides being an exemplary clinician, a wonderful teacher and mentor, and a researcher. So what other talents does she have? So somebody thinks you might be a DJ, Esa, maybe a cellist. She just looks like some sort of a musician, doesn't she? And of course, her choice of music was just fabulous. So lots of people thinking about music choices here, about musical talents here. So yeah, this is something I've known Dr. Davis. I've known Esa for a good portion of our lives at this point in time, 20 years. So we were children when we met, young children. But anyway, there's some of these things I didn't know. Like I did know, I knew she could sing, okay? But I didn't know this. Should I say it, or do you want to tell us about your specific musical
No,
gift?
go ahead. You got it. Go.
So Dr. Davis actually sang in a professional opera, Scott Joplin's Tremonesa, when she was in high school. And she also sang with a jazz band called Soul Expression when she was in college. So tell us, like, Esa, what's going on with the singing? Like, are you still doing some of that now?
So yeah, right now I only sing in the church now. So I'm only singing for the Lord. I sing on Sundays in our choir, but no, I've always enjoyed singing. My family is a musical family, particularly on my dad's side. So I would always sing with my aunts and stuff. No one's professional though. We just kind of, sing for the fun of it. And then of course, your mom drags you around and puts you in all kinds of talent shows when you're younger and stuff, right? Because we didn't have things like America Got Talent and American Idol when I was little. So it was literally around the town for like little talent shows. But anyway, and so she thought it would be fun. She told me about this opera. I was like, well, I don't want to sing an opera. She's like, it would be great experience for you to sing in this opera. So I sang as a part of the Montclair opera. In that particular opera by Scott Joplin, which is one of the only Black operas, right? Treemonesia is about an enslaved woman, Treemonesia. And so it was really, that was actually really special. And that was one of the reasons why I chose to do it, because, you know, then I kind of learned something in the process. So that was special. And then when I got into college, I had a friend who had a jazz band called Bold Expressions, and they were performing one night. He had written a song and he needed another singer because his original singer couldn't perform. And so he asked me to kind of do it at the last minute. And so I ended up getting the part and singing it. But so
Wow.
it was fun.
Wow.
I enjoy it. You know, it's fun. I love music. And so it's just, you know, something to do.
That's amazing. Well, I knew you loved music. I just didn't know some of these other little tidbits. But, and then, hey, you just dropped some Black history on us too, about Scott Joplin's professional opera. So there's some Black history for you all.
Yeah, if you ever get a chance to listen to it, it really is a beautiful opera. It is just incredible. So I would encourage you all to look it up. But Treemonesia by Scott Joplin.
Okay. Awesome. Well, we're going to move to the second fun fact, which is related to basically something that Dr. Davis began during the pandemic. So we know we all started doing different things during the pandemic. So what did she do? And I don't know how she found time to do this, by the way. She is a mother of two. And they're teenagers now. So I honestly don't know how she found time to do this and see patients and do research and do all the other things she does. So did you bake bread, Esa? Did you start painting?
No, I didn't paint. No, I didn't do painting.
But
that's because you had to be outside. There's something outside, because, you know, you couldn't do anything else. You couldn't go in anybody's house to get together. And so it was something that we had to learn, you know, we just took advantage of the outside.
They're getting closer. They're getting closer.
Oh, they are. Beekeeping. Oh, that's interesting. That's a good.
I know.
That's actually a good one.
No, but this was pretty cool. So tell us what you did.
So I learned to play golf. Right. And, you know, and I have to admit, I was in that stereotype because my husband was learning how to play golf and our kids were in first tee program. And so he thought we needed to learn something that we could all kind of do together outside and something that we would learn how to do. I had no interest in golf at all. I was like, you know, Black women don't play golf. That's not true. That's not true. That's not true. So I learned it is and really challenged myself to learn something new and to do something I would never have thought that I would do and to not have that mindset. So I was really proud of myself that I learned to do something new. And so it's been fun. Very hard to do, very hard game to learn, but
yeah, it looks a lot easier than it is. Looks like people standing around and walking around most of the time, not doing anything. I'm sure it's a lot more than that.
Yeah, trying to get a ball in a hole.
Yeah.
On a couple strokes. So.
Well, the final fun fact is something that I've been the beneficiary of myself. So Dr. Davis is an awesome cook, but I want you to kind of guess what is one of her specialties that she does.
Actually, I have to channel the ancestors to do this one. I channel them every time I do it.
Somebody put jollof rice. Jollof rice comes up often, you know, here. There are a lot of people of West African descent in this, but this time it is jollof rice.
It is around festival time. It is around a festival.
Yes, a festival. That's another hint. Chicken marsala, that wouldn't have been a bad one either. And of course, I like mac and cheese. But yeah, but tell us, there's
yes,
you got
Deidre.
it. Gumbo.
Yes,
Gumbo.
That is it. That's yes. Right. Mardi Gras. That is my thing. Seafood gumbo. And I have to kick everybody out of the kitchen when I channel my ancestors in order to get my roux together, because it's all about the roux. The roux has to work, because the roux's not right. It's not. Yeah. Yep. That's it. Every year.
So yeah. So maybe we can get her to come down here and make us some gumbo next time. I'm not sure how long we're going to be in this virtual world. We're able to get lots of people to join us virtually, but we're thinking about maybe moving back in person, and we'll have some people, of course, we'll always keep it open for people who can't come in person. But when we can get people in person, we can actually enjoy some food and music at the same time.
Oh, that'd be awesome.
But
I'm loving this group already. This is just making my day right now. I need that. This is awesome. Thank you.
Yeah. So, but anyway, so those are our fun facts for the day. The chat is always like hysterical. I'll monitor that for you. And then now I'm going to turn it over to you, to Dr. Esa Davis, who's going to talk to us about healthy mommies and healthy babies, and tell us about some of her work in the area of maternal health disparities, which we know is a sobering topic, but we always are here to uplift one another and to, strengthen and encourage one another, and just to remind ourselves why we do this work. So take it away, Dr. Davis.
Wonderful. Thank you so very much. I have to say, this was absolutely warm, welcoming, and I'm so looking forward to sharing with you all today, and a good discussion, and taking back some ideas that I know you all will have for me. I feel like I'm back at home, actually, so I'll talk about that further in my talk, but I do feel like I'm coming back home and giving this talk and being with you all, and certainly want to shout out to all of my Johns Hopkins collaborators that may be on, Wendy and Erin and Janelle, and of course, my mentor extraordinaire, Lisa. So thank you all very, very much. I'm a little bit under the weather, but I have water and tea over here, so I hope my voice will hold out to the end. I've been really trying to, fight this. I'm over the viral things, but anyway, strength, courage, and wisdom. Here we go. Oops, did I? Okay, so I do have to disclose that I am on the United States Preventive Services Task Force, and today I'm not going to be wearing my official hat, and so the views of the work and stuff that I present is really my individual views, and nothing should be attributed to the task force, except where I might note reference to them on a particular slide, and I don't have any financial disclosures. So I thought about, very sensitive to the students, and with my educator hat on, students and trainees that are in the audience. I always think it's important to share a little bit about my journey. I remember when I was at Hopkins as a fellow, one thing I enjoyed about speakers that came and talked was not just telling us about the work and the things that they did, but giving us some hint of, their path, why they chose it. So I framed this talk around, want to tell you a little bit about my story. Why do I care about maternal health disparities and inequity? A little bit about my path of how I got here. That's going to highlight my pathway through Hopkins. And then talk a little bit about the work that I'm doing to address maternal health disparities and promote equity. And then share some thoughts on, kind of some approaches where we are now with the, addressing this issue, and kind of some thoughts forward, and opportunities and research gaps, kind of highlight those. And then just finish with, certainly having a discussion and answering any questions that you may have. So in celebration of Black History Month, and certainly also Heart Health Month, in which we recognize heart disease, particularly as it affects women, I do want to acknowledge my grandmother, who is the source of my inspiration. And although she's no longer with me, having passed away from heart failure a few years ago, I do credit her for being the inspiration for me becoming a physician. She was born in the segregated South in Georgia and raised her 5 children in North Carolina. She was a registered nurse in the ICU for 40 years, although she always had the desire of becoming a physician, but did not have the opportunity to do so, although she certainly was smart enough to have become one. And then unfortunately, after failing to encourage any of her children to become a physician, she thought she would encourage at least one of her grandchildren. And since I was her first, and she did not have to work very hard to convince me, though, because I really could see her love and passion for caring for people, particularly at their greatest need. And that really resonated with me as a child, and still does to this day. And so I admire and try to embody her strength, courage, and wisdom in the spirit of NDRE's song in my work and in my life, and certainly also being that example for my daughter, who you also see in this picture, for Olivia, and also my son. So with that, I also want to share, I think that in all of my professional qualifications and perspectives as a family physician, as a health service researcher, an educator, a national and local leader kind of in this field, I think my most important qualification and perspective on maternal health disparities is being a Black mother. And unfortunately, I experienced the maternal health inequities in both of my pregnancies. So I just want to share my story with you for some context. So despite not having any cardiovascular risk factors, other than my lifelong experiences as others with the effects of structural racism, I delivered my son at 40 weeks by C-section. And within a day, I was in heart failure. I couldn't breathe, I couldn't lay down. I had pitting edema all the way to my waist. And my husband, who was a resident at the time, and I, tried to, report my symptoms, but no one was really listening to me. And they told me that my blood pressure of 150/90 was normal, and I was discharged. But then within a day, I was right back to the hospital. My blood pressure now was 220/110, and my lungs were full of fluid, and my symptoms were then finally taken seriously. So I was readmitted, but I still struggled the whole time that I was there, as the team, hesitated to take those extra steps to help me find medications that would support my desire to breastfeed. When I raised the question about, side effects that I was having, or, why I needed IV fluids when I was able to drink, then I was labeled as a difficult patient. And there were just so many moments that it was really difficult to partner, right, in my care. And I'm a physician, right, and my husband's a physician. And it actually, in order to get some help, I got my, biggest help from my lactation specialist, who, really was my greatest therapist, and acted as a liaison with my medical team. So that's my story. But fortunately for me, my story has a happy ending. I have 2 healthy children, as you can see here, and a husband who did become a cardiologist, and my mom, who's my queen over there on the left. But what my story, though, represents is very emblematic of millions of Black mothers and pregnant persons, regardless of socioeconomic status, education, or geography, who've experienced this. Black mothers and pregnant persons have the highest rate of death from perinatal complications and later life cardiovascular disease related to those complications. And we're dying during pregnancy at alarming rates, at 4 times that of other groups. And not only that, also continue to have the highest rates of infant mortality. So we clearly have a crisis that needs to be addressed. So I want to tell you a little bit about my past, before I tell you a little bit more about how I'm addressing disparities. And this is for my trainees in the audience. So I started in medical school, my research career, I should say, started in medical school. I went to UNDMJ in Newark, which is now known as Rutgers New Jersey Medical School. And I remember sitting in a class, and some representation of this graph, I tried to recreate it over the years. It seemed to be far more dramatic when I was a medical student. But basically, I was listening to a lecture on overweight and obesity, and the professor put up a graph like this, that it was stratified by race and gender and sex. And I remember just looking like, okay, Black men, white men, and then I was like, where's the line for Black women, right? And it just felt to me like it was clear off the screen. And so I was really struck by that difference and had never thought about it before then. And so I kind of walked away with this question of, why are more women obese than men, and why do racial differences in obesity among women exist? And so as a medical student, which I think is always a great opportunity to get into research, I went and talked to my mentor for the summer, and I said, hey, I'm really interested in this topic of obesity and why women, and especially Black women, are being affected by this. And of course, when you go and you work with a mentor, they may also have interest in what you're interested in, but they also have an expertise in what they're interested in. And so my mentor was very much interested in kind of mental health and family functioning. And so, you have to kind of work together to get both, both of your ideas merged into a project. And so that's what we did. We combined our interests, and we did this project, which was a qualitative study in which we interviewed African-American women of various body weight, and we wanted to know whether poor mental health and family dynamics and family dynamics of origin were associated with obesity in African-American women. And so what we learned from this project was that that obese women compared to non-obese and overweight women, they had higher anxiety scores, they rated their physical health lower, they tended to have more births, they tended to be more multiple. They reported a degree of psychosocial problems in their family of origin. And then there was no difference in depression scores. And this was kind of a big thing back then, because there was this idea that that obese persons had higher rates of depression. And that just wasn't something that panned out in our study. And so after medical school, then I went to residency. And after residency, I was encouraged, since I seemed to have this interest in wanting to have a greater impact than what I could have in the office with a one-on-one with a patient as a doctor. So I was encouraged to apply to the Robert Johnson Clinical Scholars Program, and was accepted and did my fellowship at Hopkins under the program directors Dr. Neil Poe and Leon Gordis, and of course then met my my mentor and dearest friend, Dr. Cooper, and she encouraged me that at the time there was a lot of kind of survey work that had been done in this area, really kind of documenting the differences, reasons for differences in between African American and non-Hispanic African American women, white women, in terms of obesity and causes for obesity. And so, but there wasn't a lot of kind of formative work. And so, Dr. Cooper said, well, Esa, what do these women think, right? We need to know what their perspectives are. And so, so we did just that. We did a qualitative study, and it consisted of focus groups. And what we did is stratified by race and education level as a proxy for SES. And we asked them, what were their experiences with weight loss and among obese women. And the themes that emerge from this work, and of course, with qualitative work, it's so rich with hypothesis generating data and themes, but these to highlight a few of the themes that emerged were women discuss the emotional and psychological component of weight loss. They often talked about that a lot of their negative views about weight stem from a lot of the input from their family members or from society that they received as children. There was another theme around African American women in particular were dissatisfied about their weight. And this was interesting because at the time there was this thought that and research where a lot of African American women preferred to be a higher body type and actually were more satisfied with being more overweight and obese. And that just was not something that panned out in our particular study. Also, African American women had identified that part of our subculture, also made weight management very difficult. Low SES women, talked a lot about cost concerns and how prohibitive it is to engage in weight loss methods specifically. And then this last one, women attributed, even women who didn't have issues with weight as a child or adolescent, talked about a lot of their weight loss problems stemming from childbearing. And so as I was leaving fellowship and going off to my faculty position, I really had to kind of distinguish, well, where was I going to kind of make my niche? I didn't think that with being a family physician and the perspective that I had, that there was a lot of behaviorists and PhDs doing a lot of the work in the psychosocial and kind of behavioral aspects of this, looking at this issue. So I said, well, where can I really fit? Where can my perspective make a difference? And so I thought that I could contribute more into this perinatal area, really understanding the perinatal risk factors that contributed to weight problems for women. And so it's kind of how my research has unfolded over the years. So I started with this kind of broad question, but having this kind of life course perspective as a family physician, spent the early years looking at psychosocial and behavioral factors, and then moved more into studies that looked at perinatal risk factors and also obesity-associated diseases such as gestational diabetes. And then now have really in this latter part of my career focused more on interventions and prevention strategies. And so I'll kind of talk about a little bit of all of these. So the first is just to highlight, we did a study looking at, understanding race and SES differences in the incidence of obesity related to childbirth. And so we used the National Longitudinal Survey of Youth, which is a prospective community-based population-based study. And we had a sample of about 3,000 women that were 14 to 22 at baseline, non-pregnant, non-obese, never gave birth at baseline. And we wanted to know what their 5-year incidence of obesity was. And so kind of what we've learned from this study was that the 5-year risk of obesity was about 3.5 for childbearing women compared to women who had never had children during that time period. And that for primiparous women, the risk was doubled, and multiparous women having more than 2 children tripled the risk of obesity within that 5 years after childbirth. And that when we looked at African American women, Hispanic women, and non-Hispanic white women, African American women had the highest peri-related obesity incidence. And then what was really interesting is in this group, so remember, these are women who were not obese at baseline, but of those that became obese in that time frame, a majority of those women remained obese or severely overweight, BMI of 27 or above, in those 5 years after childbirth. So basically saying that once they became obese in pregnancy, they never went back to being normal weight at their baseline. So then we also looked at other factors, interpregnancy intervals, how many children one had, and whether or not gaining a lot of weight in that first pregnancy those were risk factors that were all seen as major causes of maternal obesity. And so again, we used the same cohort to look at these particular factors. Again, non-obese, non-pregnant, between 14 and 22. And in this large prospective community-based cohort, which looked at over a 10-year period, we looked at several different intervals. So short interpregnancy interval of less than a year, 12 to 18 months, 18 to 24 months, and above 24 months. And the short story is that in looking at the short interpregnancy interval, had the highest risk of obesity compared to those that had the longer intervals. But that it wasn't just the interval, it was that weight gain in that first pregnancy really made a difference. So with or without a short interpregnancy interval, that having that increased weight gain in that first pregnancy really increased the woman's risk for obesity. And if they had both excessive pregnancy weight gain and a short interpregnancy interval, that just increased the risk even more. And so then I kind of moved into intervention trials. I just wanted to highlight a study that we did looking at screening strategies for gestational diabetes. This was the R01 funded study that looked at two predominant screening strategies. So our current screening strategy is a two-step screening strategy known as the Carpet and Houston strategy. And then there was a new one being proposed by the International Association for Diabetes and Pregnancy Study Group, which is like a one-step test. And there was some question about whether or not the one-step test would be something we should move to because it would be better for identifying women that had gestational diabetes and hopefully improve outcomes. And so we conducted the study. It was a randomized comparative effectiveness trial that we conducted at McGee Women's Hospital. And we recruited women from our 10 outpatient clinics. We randomized 920 women between the ages of 18 and 45 that had a single pregnancy, and that were between 18 and 28 weeks of gestation. And not to kind of go through the study design, but basically we randomized them to the two screening arms. So as you can see here, they either got the 2-hour oral glucose tolerance test, or they got the common 3-hour. And then we looked at our main outcome was large for gestational age birth. So what we concluded from this trial was that when you use the IAGPSG screening criteria, or the one-step test, it does increase the number of women that will be diagnosed with gestational diabetes. So like 15% compared to 5% in using the Carpet and Houston criteria. And they would also increase the risk of those that would be treated with diabetes medications, and also then those that would experience a little bit more adverse effects, which we saw with that group also having an increase in neonatal hypoglycemia. But that when you increase in the intervention, though, in this in this arm, it didn't reduce the risk of LGA, which was the main outcome, and it didn't make a difference in terms of C-section deliveries between the two arms, and also didn't make a difference between maternal and neonatal morbidity composite. Okay, so now I want to move into what I'm some thoughts specifically on addressing maternal health disparities, and kind of where my work has moved in these latter years. So as you all know, that we're seeing a crisis in our country right now with the increasing rates of maternal morbidity and mortality, and the disparities in those morbidity and mortality, again, with Black women having the higher rates of both morbidity and mortality related to pregnancy, and really driving the overall rate is the reason why we're seeing the increase, in the United States. And that obesity, again, is one of those major drivers. And so this is, as you can see, a graph stratified by race, so non-Hispanic white, Black, Hispanic, and Asian. And then, as you can see with the red line denoting obesity, with adverse pregnancy outcomes on the y-axis, that in all the groups, having obesity increases those adverse pregnancy outcomes. But then among, non-Hispanic Blacks, they tend to have still a higher rate of those complications related to obesity. And the other major driver of these pregnancy complications and deaths that we're seeing are related to hypertension disorders of pregnancy. And they're becoming very, very prevalent and making up about 10% of all maternal deaths. And just, we're putting a little bit of a commercial here because this is really hot off the press. So I will put my official United States Preventive Services Task Force hat on for just a second, because yesterday we released our draft statement for screening for hypertensive disorders of pregnancy. And we have come out again with a B statement, a B recommendation that all pregnant persons should be screened with an office-based blood pressure at every prenatal visit to identify the hypertensive disorders of pregnancy, and then be offered, the appropriate treatment to help decrease the morbidity and mortality that we see, both for mom and for baby. And one of the things that we are highlighting, with this recommendation as well, are the disparities that Black women and Native American and Alaskan American women have a higher rate of hypertension disorders of pregnancy and complications related to hypertension disorders of pregnancy. And that, more is needed, more research is needed to understand why these disparities exist, to address the barriers, and to also improve screening, particularly in these populations, so that they can be offered, that equitable treatment to address this problem. Oh, and the other point I want to make about hypertension disorders of pregnancy, right? It's not, the interesting thing about this particular disorders is not just something that affects the pregnant person and their baby during pregnancy, but it's also something that we know is linked to long-term cardiovascular disease. So it's not just a problem of today, but potentially also ends up being a problem for them for tomorrow. And this is, I just want to highlight this one study from a colleague of mine, one of my mentees, who did this study. At our institution, we have a home blood pressure monitoring program that is like the standard of care for women or for pregnant persons who have had a hypertension disorders of pregnancy. So when they deliver, they all get offered this 6 week of home blood pressure monitoring in this program over the 6 weeks postpartum. And it's really been shown to be effective in helping to lower blood pressure in this group. And it's a kind of bi-directional, program in which pregnant persons are able to monitor themselves postpartum, but then feed that information back to their physician and get the care in a more timely fashion. Well, this was a study to show that when you do that, you give the standard of care across the board. So all women that have hypertension disorders of pregnancy receive it. You can see that in the first frame is systolic blood pressure, the second frame is diastolic, and the last one is mean arterial blood pressure. The blue line are Black women, and the white line are representing white women. And what's really interesting is that, so you can see that in all of the frames, right, blood pressure does come down for both groups, but Black women still have a higher systolic, diastolic, and mean arterial blood pressure even after 6 weeks, right? Even after receiving the same standard of care. And so there have been, you all, kind of know, not necessarily unique just to this topic, but other topics as well, that the challenges to addressing maternal health disparities really, I think, can be summarized in these 4 bullets, right? So, still addressing structural and systemic racism and inequities in the social drivers of health. We still are experiencing Black and brown persons not being seen, heard, and valued, even as highlighted in my own story. Insufficient attention and support in the postpartum period. There's also the insufficient partnerships with community health professionals. And then this insufficient diversity, equity, inclusion that we have in our biomedical workforce. And so the first, part that I think is really salient, and I know, you all have probably done in your work as well, right? And it's that listening, right? That voice, being able to see, hear, and value what people are saying, what our participants are saying, and then being able to incorporate their, their voice and their experience and their pain points in a meaningful way within our research and also within our medical team. And really learning how to do this is one of the ways that we can, move the needle, I think, for promoting equity. And so one way that I think is an approach that can be helpful in doing this is that collaborative model. And one of the things that we're doing in this space is thinking of collaborative perinatal care, right, that can help to reduce disparities and promote equity. Being able to come up with collaborative care models that integrate community-based teams, that can help lower social barriers, increase access to health information and services, reach populations that are hard to reach, focusing on prevention and management of disease, and certainly being able to better connect populations to medical services a lot earlier. And so, as I know Dr. Cooper does in her work, there's this huge benefit to collaborating with community-based teams, right? Often these teams are trusted sources. They represent the communities they serve. They're able to provide that education, social, cultural, and emotional support. They're able to help patients access or navigate medical and social services. And we have a lot of examples of these community-based teams. And these are just ones that have been, that focus on, have been used to focus on maternal and child health disparities. So lactation specialists, community health workers, your postpartum and pregnancy and postpartum doulas, and then the home visitation program. So I just want to highlight one of our team's strong and well-established partnerships that we have, and that's with our Healthy Start organization. So Healthy Start is our community-based program that consists of community health workers, lactation specialists, mental health specialists, doulas, childbirth educators that are mostly, again, from the communities that they serve. And they provide support to pregnant and postpartum people and their families. And their whole mission is to improve maternal and child health and to reduce these adverse birth outcomes and to promote equity. And they serve about 80% women and infants of color in our, southwestern Pennsylvania area. And so I want to talk a little bit about a new project, a new R01 that we recently got funded, my colleague, Dr. Katov and I. And this is a trial that is designed to enhance or to test an enhanced care intervention, but this enhanced care intervention is a real collaboration between our kind of medical team, but being delivered by our community-based partners, and that versus our usual care arm. So I'm going to talk about that a little bit more in a minute. But that what was important about this team is that you see that we're kind of a multidisciplinary and diverse team that brings together our community partners as co-investigators. So this idea of not partnering with them in a way that where we come in and have them help us, get participants, but really having them at the table as co-investigators, giving us input from start to finish, and being involved in the delivery of the intervention. So just to go through our approach, so we are interested in eliminating racial disparities in mean arterial blood pressure in the year after delivery among women who have disorders of pregnancy. And we are going to do that by leveraging our hospital's home-based blood pressure monitoring program that we already have. So that's our usual care, but enhance that with a partnership with our Healthy Start partners to deliver an enhanced care part of that intervention. I'll talk about that in a minute. And our goal is to improve postpartum blood pressure to decrease the incidence of chronic hypertension, CVD, and mortality. And our kind of novel about this piece is that we've rooted our enhanced care intervention within our health equity framework to improve postpartum blood pressure recovery, and with the goal of closing that black-white blood pressure disparity in the year after delivery. So just to show you our study design, so we are going to be randomizing 450 participants, all who have been identified as having a hypertensive disorder of pregnancy, and they'll be randomized to our usual care arm. So again, it's our home blood pressure monitoring program that delivers 6 weeks of blood pressure monitoring postpartum. And then that compared to our usual care arm, or our enhanced care arm. So it'll be they'll have the usual care of the 6 weeks blood pressure monitoring, but then we'll go on to continue monitoring their blood pressure and weight for the total of 12 months. But our enhanced care part is going to be having a heart health trained postpartum doula who will deliver more support for these participants postpartum, and I'll talk about their specific roles. So our doulas will deliver our heart health intervention. So these are highly trained and trusted caregivers who already advocate and support participants postpartum and do that really well. That is their expertise. And we're just going to augment their already incredible skills with modules that really focus on kind of the life essential aids, right? Really showing more on the blood pressure and CV health kind of education, so that they are better able to educate participants on blood pressure and CV health, and then be able to make the appropriate referral. And so all of our doula intervention will support the new skill acquisition for mothers and postpartum persons. So provide that support for self-management, physical and emotional health, cultivate opportunities for socialization, certainly capturing their stories and experiences, and also encouraging the accountability. And so what this looks like in our first 8 to 12 weeks, all of the participants will get one-on-one support. So again, the doulas will provide health education, addressing all of the life essential 8 cardiovascular risk factors, so diet, exercise, smoking. And then they will support their adherence to blood pressure monitoring and the medications, and then certainly assist with any kind of health care that they may need or access to care and connecting them to services. And then the weeks 9 to 12 to the end of the intervention, they will transition from an individual doula to a doula-led peer support group. And then the participants will come together in 6 sessions over 8 months postpartum. And again, the goal here is just to continue to support the participants, reinforce their skills with ongoing blood pressure and weight management. And so I'm happy to talk a little bit more in the Q&A and certainly come back. We're actually gearing up for recruitment now. So I would be happy to come back at a later date to share our experiences and our results. And I want to just quickly talk about another kind of program project that we're doing that stems from the home visitation programs, which I think is another opportunity to also help to address promote equity and address these maternal health disparities. And postpartum home visitation programs, have been conducted by a variety of health professionals, from nurses to laypersons. And the goal is to help improve their health and prevent them from, a lot of these conditions from becoming chronic. And right now, the evidence shows that, these programs, to varying degrees, increases maternal satisfaction with postnatal care, and can improve things like exclusive breastfeeding rates. But the research gap still is, there's not still a lot of evidence of that home visits decrease newborn or maternal deaths or serious maternal health problems. So there's a real opportunity for more research in this area. So one of the models that has been used in promoting positive child behavior has been this family checkup home visitation model, which is what we use in our area. And this is a model in which parents are the focus. So there's a lot of parental training at different developmental transition periods, right? Those birth, childhood, adolescence, and usually focuses on families that experience a little bit more adversity and could use that support. So I'm going to talk about another project that we are involved in, the Enrich study. And the idea here is, to provide evidence, can we use these family checkup models, these home visitation models, can we expand them in early childhood to address things like cardiovascular health in mothers and young children? And so there's a new funded multi-center project called Enrich, of which we are one of 7 sites. This is sponsored by NHLBI, the Health Resources and Services Administration, and the Administration of Children and Families. The overall goal is, again, to improve the cardiovascular health of mothers and children by adding this kind of CV cardiovascular health promotion intervention. And can you use this home visiting program model? So we use the family checkup model. So our idea is we would adapt the family checkup model to focus on family checkup heart. And what we would do is train our home visitation kind of team, equipping them with more instead of behavioral focused kind of interventions, really heart health focused interventions that would again address life essential aids. So we will focus on mothers that are at-risk mothers and pregnant persons who are low income, Medicaid or WIC eligible, and their infants. And again, the hypothesis really, can you use these already well-established home visiting programs, can you adapt them with CV health education and support to deliver prenatally and postnatally to these mothers in an effort to improve their cardiovascular health and that of their babies. And so our team is going to leverage our community. Again, it involves very much a community-based approach. We're partnering with our Health and Start partners to address CVH after a high-risk pregnancy. And so our multidisciplinary team, again, uses our collaborations. We're diverse in terms of gender and race, and then our experience. So we have primary care, developmental psychologists, PD, health specialists, OB, prenatal care. And so here's our team. Our team is being led by Dr. Kay Top and Danny Shaw. And again, our community partners are very much at the table as our co-investigators, because their perspective and bringing that community perspective in the work is really important to delivering the interventions. And so just to kind of summarize, I just want to leave you with a few points that, again, Black mothers have the highest pregnancy-related deaths. Hypertension and obesity are major drivers of pregnancy-related morbidity and mortality. I do think we have some opportunities. The postpartum period continues to be a really nice opportunity to address a lot of the social determinants of health, to provide support, to prevent chronic disease, and to also empower women and pregnant persons during that time period to in self-care. And then I think our community health partnerships can improve health outcomes and self-advocacy in our pregnant people, and we should certainly be partnering, doing more to partner and collaborate. And so just a few ideas for some, to summarize knowledge gaps and research opportunities. There's always a need for more representation in RCTs among participants and among the investigators. It's one of the things on the task force that we, constantly run into are RCTs that are only done in, homogeneous populations and not representative of, the full spectrum of people that they should. And so we really should continue to push for more representation in these trials and in our studies. It is so important to elevate and incorporate patient stories, experiences, perspectives, understand their pain points. And then I think, having more research that establishes the evidence on the effective strategies for integrating and evaluating these medical community partnerships that particularly in this case deliver postpartum care to specifically address maternal health and equity are still going to be needed. And certainly more RCTs to evaluate, particularly these home visitation programs and all the different types of models like we're doing in Enrich, to understand things like timing, frequency, how much, and really explore what can be done by adapting these models and how they may be effective in improving maternal and infant outcomes and certainly promoting equity. And then finally, I think there's also room for, as technology continues to grow, telehealth and remote monitoring, we need studies that will evaluate the communication and transitions of collaborative care between the medical team and the community-based teams. And we certainly can explore the role of technology in facilitating, that communication and also in improving outcomes. And so with that, I'm going to stop and just, again, in the spirit of Heart Health Month, that help, as I started, healthy mommies do equal healthy babies, and that every person deserves the opportunity to have a full and healthy life. And so with that, I will stop sharing. And I'm happy to take any questions or turn it over to Lisa.
Thank you. Thank you so much. No, it's not turned over to me except other than to moderate. I'm sure what's going to be a lively discussion. So first of all, thank you. Thank you so much for such an insightful and just beautiful presentation of, I think, not only the work itself and the topic area and the problem, but just the personal story of your career and how you kind of moved from one phase to the other in answering some of these key questions and who some of the people are that have worked with you and including your community partners. I just love the fact that you wove all of that into this beautiful presentation about an area that I know is like so important and really close to the hearts of so many of us. So thank you. And I mean, I see a lot of expressions in the chat saying similar things.
Oh, thank you. I hope I struck the right balance. It's always so hard to, you always want to say so much. And so
I think you struck.
I appreciate the feedback.
I think you struck a perfect balance. And I just love your take home messages too, because I think that because it's so complex and there's so many different things going on that sometimes it can be hard to know, like, well, where do we even start? And I love the way that you talked about the representation and making sure that we are including so many folks that actually haven't been studied so far, and then also the fact that you really centered like the role of patient voice. And we've heard from other colleagues, I'm sure, who are on this call who will definitely resonate with that, who have shared some of their work where they've tried to center the voices of birthing persons. You talked about partnerships, community partnerships, which I think is definitely, again, we know is critical because, they're the people who are in the communities and who know the folks we're talking about and who know the problems very intimately and know the solutions. And so talk about not really making this a research-centered agenda, and then also brilliantly about the specific scientific approaches and what we don't know so far. So, those are some of the take-home messages I had from your presentation, and I, plan to sort of really think about that a lot more. And also just, I think the connections between some of the issues we see in some of the general medical patient populations and how they kind of dovetail, because you're seeing people that are somewhat younger than the people that a lot of us see. And we also don't see them during the time that they're pregnant that much. We often see them like much later, when some of those issues have already happened. Now they have hypertension. Now they've gained excess weight, and we're trying to help them figure it out. But how wonderful would it be if they had help sooner, in that immediate period? So, yeah, you gave me a lot to think about, I know. So I want to see if anyone else has any questions they want to ask of Dr. Davis at this point in time. I know that there are some maternal health researchers on this call, but aside from that, we see community partners. I see.
Oh yeah, I'd love to hear hear some of the things that are going on too, because I think, there's always that, and I'd love to the people who are doing the voice work. I think one of the things that it's just so interesting with all of our, rigorous research that we do in our methodology for measuring and all of that kind of stuff, how you can still miss the voice though, right? Like how you can still, right? Like I think that one, the study I highlighted of my colleague who did that study of showing, when you give the standard of care, right? We've talked about that, like, oh, you just need to give the standard of care, give everybody the same thing, and that will take care of the disparity, right? And we see that it doesn't, right? So it's saying that something else is happening, right? Something else is happening, because if you give everyone the same thing, yeah, you should see it. There should not have been a disparity. It should all have been decreased, right? Or maybe, there's some women that, that didn't matter, but it should have been together, right? But the fact that you still see those curves separate, like, well, what is it, right? Did the nurses not give this woman the same instruction as this one? Or maybe it was her tone of voice, or maybe it was, right? We just assume that, well, she got instructed the same way and she got the equipment, but, maybe something else happened in the intervention in that interaction that we're not capturing, in the way she was treated or the way she was spoken to, right?
Absolutely. So many unanswered questions. So I see Dr. Opara has her hand up.
Oh, sure.
So we'll take her first, and then we'll take Blanca Alvarado after that. So Ijoma?
Yes, Dr. Davis, thank you so much. Outstanding presentation. I took a lot of notes, not just from the content, but even just your.
Oops, you muted yourself, Ijoma.
Yes, it happens. Sorry, I'm back. I took a lot of notes, not even just from the content, but even your presentation approach. To your point, the topic is vast and complex and multi-pronged, multi-layered. But the choice to use your personal story, I think, was outstanding and really tied everything beautifully and grounded the work in a very meaningful way. And so I appreciate that tremendously. And as I put in the chat, I think many of us, including myself, can relate to your story, and something similar happened to me. And I lost my protective health immigrant. I'm sure you've heard about the immigrant protection. When Black immigrants move in, that first 10 years, baby, you're sort of like exempt from the effects of structural racism and white supremacism. But after those 10 years, boom. And I know for me, after my third child, those hypertensive disorders of pregnancy, I fell victim to that, and I'm still living with the consequences today. So with that being said, I just want to appreciate not just the work that you do and the content of your presentation, but even the approach that you chose. And speaking of, Dr. Cooper lifted up again how you kept emphasizing patient voice and voice. What I want to lift up inside of that is I'm wondering, as I sit with your doula program and the working with doulas to help address the hypertension and cardiovascular health with the patients. And you mentioned story quite a bit and the centering of story. And so as I think about that, I think about your story, my story, and many of our stories. I also think about the trauma involved and the risk of traumatization and re-traumatization in that process. And so I wonder, has that shown up in your conversations? How are you accounting for that or taking care of that or addressing that? In other words, what is the trauma responsive and trauma informed approach that you have sort of embedded in your work as you incorporate story, knowing that many of our stories are really grounded inside of trauma?
Yeah, thank you for that. And actually, I was involved in another project and effort with my colleagues at Hopkins and also at Temple, who have done a lot of the trauma-informed work in really thinking about these pain points that happen along the way. And one of the things that we're doing in this particular trial, and I think that's the kind of the beauty of partnering with Healthy Start, because this is what they do every day as doulas for this community, is to be that that safe space, that voice, and building in a component for addressing the trauma that occurs through things like mindfulness practices. So we have a psychologist who does a lot of mindfulness work, who's going to be helping to support the doulas in developing that piece of it too. So being able to bring this kind of mindfulness component as a way to respond. But one of the things that the doulas are trained to do, and they do really well. And I think one of the reasons why, kind of separate from our study, that Healthy Start has just been such a vital force is because they address that piece, and the women and the pregnant person feel safe in that space. We're trying to with more resources in terms of dealing with that trauma through things like mindfulness and other kind of support around the mental health piece of it. And then thinking, and honestly, we're in that early stages of thinking about, and we've been talking about this as a team, how to feed that back to the medical team, right? And so when it does occur, and if it does occur from the medical team side, we're still thinking through how are we going to feed this back to the medical team, and thinking about, the potentially training and things that would need to be done.
So you mean feeding back the information that maybe the medical team and the medical experience contributed further to that person's trauma?
Correct.
Yeah, I'm understanding that.
Yeah,
these are fascinating issues, because I think that there are so many, of course, health professionals don't go into medicine thinking that they're going to be traumatizing people, but there's the reality there that our environment and the stresses that we're under ourselves don't always put us in the best position to deliver care in the way that we would want to. And so there's like the need to kind of foster that openness to that kind of feedback, and sort of make it a safe space for the health professionals themselves, so that they don't become defensive and argumentative about it.
Right. And unfortunately, this trial doesn't address, it is something to think about for the future in terms of, but, unfortunately, this particular trial focuses really on the participant, doesn't focus on addressing the healthcare, the healthcare team with an intervention.
Mhm.
You know, certainly we are designed, and the doulas are designed and trained to help support the participant to advocate and stuff. But you know, that is something, you know, I think definitely more research needs to be done on is in, you know, and like I said, our colleagues out of Temple are doing a lot of work with actually a system-based trauma-based intervention to really address the medical team side of things, which is really, you know, really exciting to watch. So it's happening, but certainly there's room for more of it to happen.
Right. No, I think one of our colleagues, Kelly Bauer, was sharing with us some of her work where they actually engage with health systems around, you know, training around this very issue. Like, what's the role of the health professionals within the care delivery system, you know, to addressing this problem. But I want to make sure Blanca Alvarado gets to ask her question. So Blanca, and
Hi, good afternoon, and
Good
thank you so
afternoon.
much for your service, both Dr. Cooper, Dr. Davis. My question is, would your study include some of the effects, which are pretty severe for some of moms, some of the mothers? Postpartum depression is a very it's complex. I know I experienced it. I had a premature baby, and so when you come home with a monitor and a CPAP and you know, and a just all of the it. I was like, how do I parent? How do I do this? And so I was wondering if you know of any studies. I am also a bilingual research assistant that I am excited to be in that role because the language barrier is also something that is so. Can you imagine someone who doesn't even understand what the prematurity birth was going to, no doctor can ever promise that that baby is going to be okay. And so between the postpartum depression that can occur and the premature birth, that still it is a high number of prematurity. Are there any studies, or will your particular study address a part of that?
Yeah, so let me take your first question with regards to addressing postpartum depression. So in this particular, well, in both trials, both the enriched trial and for our site, and also for this severe morbidity mortality trial that we're doing. So we are addressing, and one of our co-investigators is a psychologist, and does a lot of the kind of perinatal mental health piece. And so we are specifically addressing depression, anxiety, and any and even PTSD, which can happen particularly after a hypertension towards a pregnancy, because a lot of these women will go on to have a very traumatic birth experience, unfortunately. And so, we are paying particular attention to give the women support and services to address that. And the doulas will be trained to be able to identify and be able to connect the women back to services that we have at McGee. Because you're right, it is really a tremendous problem. And then in terms of the bilingual piece, so I think you're underscoring, the point that I was making about, representation is important, right? I mean, it continues to be really important. Having representation within the investigative team or the research team, the medical team, right, to be able to help all participants who are particularly bilingual be able to navigate. And so I think I think that while that continues to be a goal, and it should be a goal if we're really going to address maternal health disparities, we're going to just have to do better in that regard, because I think the point that you're making is exactly right. It is, and I think in our particular trial, do have, as part of our Healthy Start, we do have doulas who are bilingual. We do not have a large Hispanic or Latina population in our West Pennsylvania area, but we do have research team members and doulas that will be able to address that population. But I agree, it's not sufficient. I mean, I do think, across the board, we need to have better representation. I think that's just what's going to go a long way to helping us address this.
Thank you. I see Dr. Chidima Ibe has a question. And then,
First of all, Dr. Davis, your talk was just exceptional. And I know everyone has been praising how great it was, but thank you so much for presenting your work and really for exhibiting so much persistence, because as you were talking, you noted all of the different funding mechanisms that you've applied to do your work. And I thought that was great. That's not what I wanted to ask you about, but I just wanted to mention that I really was inspired by that. You just mentioned representation, and I really loved what you said about including community partners as co-investigators on your team. And there are several projects underway within the center where we've tried to do the same thing. I was just curious what that process has been like for you. How did you select those specific partners, and what types of things did you and your partners do to kind of build each other's capacity to work effectively with each other?
Yeah, that's a great question. Because you're right, it didn't happen overnight. And Healthy Start has always, has been in the area servicing our patient population for quite some time. And I think it started with a smaller project at first, right? Kind of saying, hey, would you like to be a part of this? You're taking care, you're taking care of these women too, and have a perspective, and inviting them in on the project. Not necessarily as an investigator initially, because they didn't necessarily have that capacity, but invited them in because they had a service, they had the patient population, and we had mutual interest in terms of what we were trying to do. And then just as they, part of it is also, in these relationships, as they bring a certain level of expertise, right? They know the community, they know the voice, the doulas and their community workers are good at delivering the care that they deliver. And they've got a lot of great insight and perspective. And so it was starting, we would invite them in on, research that they were doing. They would invite us in to do videos and health videos that they could push out to their community. So we were kind of establishing this relationship on both sides for a long time, until we had, honestly, an opportunity, now with the which is really encouraging, the way the funding has gone is, the funding mechanisms have been more friendly to having community workers at the table, right, where that may not have been there before. And so, that has really helped to be able to bring them on as investigators. And, certainly, we may have the methodology part of it, but they have, everything else, right, the perspective. And so I think that really is what helped in this latter part of elevating them to the co-investigator status, where we could bring them on. And then also, building, to your point of building capacity, being able to support their infrastructure, right? Having their ability to hire another doula or to hire research assistants to be able to help them, with that part of the project, or have some indirects to be able to, build more infrastructure in their community. And so that's really been helpful, I think, in terms of building their capacity as well. And, we also had to figure out, the whole kind of, I don't know if you guys have the city modules, the, human subject, ethical, responsible that you have to do. And so, building and creating modules for them to be able to do so that they can be up to speed and stuff as well. So we've really invested in them. We invite them to all of our, they're part of our research meetings. They come to a lot of our, our seminars and work groups and stuff. So we really do see them as partners, and vice versa. They've invited us to a lot of their events and programs that they're doing, and often are helping to support them as medical experts in what they've chosen to do. So that partnership grew over the years. But I think the funding mechanism and the funders being more friendly to having them be co-investigators, where you can elevate to that status, has really been what's been helpful. And it's certainly, we've always invited them on publications and things of that nature. But
Awesome.
yeah,
Awesome.
so I think this funding has really helped to pull community partners in, and the requirement. I mean, that's actually what's been real. When I started out, you mentioned my funding, it was really hard, at least Lisa could tell you, it was really hard to publish, because there was no place to really publish. Who wanted to hear about mommies and babies, right? Nobody wanted to hear about mommies and babies, right? Because OB journals were about, the technical parts of the delivery, that's what they wanted to publish, right? And pediatric journals were like, okay, we're about the baby, we don't really care about. But so it was really difficult to figure out, where does the work get published, right? And same thing with funding, who's really interested in funding moms and babies. And so, really since the 2020, I think with the uncovering of all of the disparities that COVID really highlighted, and the attention to structural racism, really has provided an opportunity for funding, for people to focus on maternal health disparities. And the funding now is just, really increased. And the need to, in that addressing it, you have to have community partners. You have to have them at the table. And so, that's really been exciting to see.
We're certainly excited to see that. We know in the cardiovascular field, we're not that much further ahead, but we saw a lot of that before. And unfortunately, it's taken a long time to get to this point. But fortunately, as you said, it's an opportunity that I think a lot of us are seizing upon. I want to make sure Dr. Matthews gets to ask her question, because I see we're winding down. So Lena Matthews.
Thank you so much for this opportunity to ask this question. And Dr. Davis, it was a phenomenal talk. I really enjoyed it, echoing what Dr. Ebay and everyone else has said. I'm coming from the background of a cardiologist, and your research has really highlighted the burden of cardiovascular disease that occurs, especially in the postpartum period. And I want to tie that also with your role in the USPS, so in health policy generation. So typically in the postpartum period, I think babies are seen within 1 day of leaving the hospital, and it's really close follow-up. But on the other hand, for mothers, they're given a postpartum visit that's 6 weeks away. And in that time point, there's no one keeping track of them, keeping track of their blood pressure, any symptoms, unless they elicit themselves and reach out to their medical providers. And as you highlighted, especially for postpartum hypertension, it can present a few days after discharge. So in your role, in your research and in your role in policy making, what is happening in terms of having women have much more closer follow-up with their OBs, in the immediate postpartum period?
Yeah, so, that's a huge question. I'm going to answer it in several different parts. So first of all, I think just the attention to the postpartum period, there's those of us who keep drumming that, raising that awareness, pay attention to the postpartum period. I know your very own Wendy Bennett is another one, right? We're trying to, focus on the postpartum period as it really is an opportunity. And like you said, women go 6 to 8 weeks before they're, often seen. And so, there really has been this push, this idea to extend kind of prenatal care, to extend it all the way to the postpartum period, and up to a year postpartum, and kind of push Medicare and Medicaid and the insurance companies to cover it as a true postpartum period, just like we do prenatally, that you come all the time, that this would happen. So there are those of us who are trying to champion that idea to extend the care all the way to the first year postpartum. There's also, this focus on transition of care is always a big one. And this is, highlighting again a lot of Wendy's work. Can we better connect OB and primary care? Because that's where primary care needs to come back in. Family physicians, general internists, need to come back in and take, care for these women right after delivery, right? Can we transition them back to, their primary care physician who can also, work with them and screen them and care for them during that time. So there are those of us kind of working on, making that happen, that transition of care happen. And then I think this is where the space where a lot of the technology could potentially happen, right? Telemedicine, remote monitoring, and using, a lot of those ways of being able to monitor women in this period a little bit more too, right? So with our home-based remote blood pressure monitoring program, there is this bi-directional feed of the women take their blood pressure. It does go back to the medical team, and the medical team can address it in real time. So, I think, things like that can also certainly help. And then we're also seeing, in our hospital, our maternal fetal medicine docs, we have a postpartum hypertension clinic, so that women who have hypertensive source of pregnancies will, be enrolled in that clinic, so that there is someone following up with them in a closer time period, over those 6 to 8 weeks or over those 6 months, that you still see it becoming a problem. So there are some examples, there are some models that people are trying. Certainly there's more is needed to test for the efficacy of those things, and also scaling it up, right? I think we need to share kind of more experience of what we're doing at our institutions, of what works. And then, of course, you got to prove it. And you certainly got to prove it in order for it to rise to the level of, and so I'll, with my hat with the U.S. Preventive Services Task Force, we make screening recommendation of preventive services that affects the entire population, but we only can consider the evidence that's available, because we're not a body that, unlike some other organizations where we come to consensus on it, we don't do anything by consensus. We only evaluate the evidence that's there. So if the randomized controlled trials are not there, that's all we can consider. And so then we end up, when you see some of our recommendations, we end up with I statements, right? We don't have evidence that says it's good or bad, it's insufficient. So I think, keeping that in mind, that we do need to design trials. We do need the level of evidence to show the efficacy and the effectiveness. And we ideally need to do that in populations that are represented, so that we can make statements that broadly affect the entire group, or be able to say something about specific groups. And unfortunately, at times in different topics, we don't have that level of evidence. So I know that was a long-winded answer, but I hope I answered your question.
No, I mean, I think you really raised the point here, and like to let all the folks on the call know, there are still opportunities. Sometimes when you're a young investigator, you think, oh, everything's already been done. But, if you think of a question and you look it up and you see that nobody's actually really done a study on it, that means the world has been waiting for you to answer it, and to do that. So there's still a lot of more work to be done.
There is. And one secret I would put out there for early stage investigators to that point, Lisa, is if you just start with the USPTS task force recommendations, when you look at any of our recommendations across a variety of topics, cardiovascular, pregnancy, right, all of them, we always, at the end of our statement, particularly of our I statements, right? Because usually our A and B statements are usually what gets cut, you should do it, right? All primary care physicians and clinicians should implement the screening, because the evidence is there that there's a substantial benefit. But the I statements are where there's usually some gap in research and knowledge. And when you go to the recommendation statements, we tell you exactly what research is needed. We tell you what's missing. And we are highlighting health equity gaps. That is our thing that we're doing now. So you can go and you can see where the health equity gap is in those recommendation statements, and that is where the research is needed. So that is just, you know, across any of those topics. But if they fit what you're doing, you know, think about that in your projects and say, well, how can I also generate evidence that will help us get to these policy decisions? Because the evidence does get into the recommendation statements. We can only evaluate what is there.
Well said. Well, so with that, I just want to thank you again, Esa, for a very enlightening and inspiring talk. And of course, just continue to wish you all the best in your amazing career that I've been fortunate to be a part of. And just to say to everyone, have a wonderful rest of your day and week, and happy Valentine's Day. Yes. Continue to uplift Heart Month and Black History Month, and reflect it in what you do. And we look forward to seeing you next month at our jam session next month. So take care.
Thank you so very much.
Bye, everyone. Thank you.